Okay, we are streaming. So Representative Devon, I think whenever you're ready to begin.
All right. Well, Julie, thanks for all you've done. And I know that's an interesting time for you to put all these IT stuff together. You never thought you'd probably be such an IT genius, did you? So
Definitely not.
We appreciate all you do and how you've adjusted to all the different things that we're doing today. And I know you normally would have welcome, and I don't know if we want to do the full agenda, if we can skip the introductions, but I know we do have a new member. Julie, I don't know if you'd like to introduce our new Senator Donato.
Yeah, so in early July, I received word from Senator Bray's office that our new member as representing the Senate Republican caucus would be Senator Stacy Donato. So welcome, Senator Donato. Where are you?
Thank you.
Oh, there you are. So welcome to your first commission meeting.
Thank you.
Mm-hmm.
Stacy, only a few of the members bite, so I wouldn't worry too much.
Well, that's encouraging, and it's early today.
Most of them are pretty harmless, but they're all good people. So again, thank you for everybody taking time out of your morning to be with us. And I know to move forward, I don't know if you want to introduce anybody else, Julie, or if we're okay to roll.
Everyone who's on should be a commission member or else someone who's scheduled to speak on the agenda. I would like to ask, there's another person who's joined by phone from a 480 phone number. If you could identify yourself. Not sure who that is. Perhaps we'll find out over the course of the meeting. But I think as everyone's name is on their box, I think I agree with you. We could skip the intros.
All right. Thank you again. And to move forward, we'll just move forward with the approving the minutes. Or do we want to do all the consent agenda items? Does anybody want to pull any of the consent agenda items out separately? So we have the minutes, the equity guide, and the approval for the fiscal year 2020 annual report, and then approve the YRBS letter of support. Do we have any comments, or do we want to pull anything out separately? I'd take a motion to pass the consent agenda items, or have a consent.
So moved.
Consent.
Very good. And then the data sharing and mapping with Tyler Brown.
Yep, I'm on here. Can everybody hear me?
A little soft, but I'll turn my volume up.
Sorry. Yeah, so my name's Tyler Brown, co-chair of the Data Sharing and Mapping Committee. Thank you everyone for allowing me to speak today. I won't take up much of your time. I'm going to try to share my screen so that I can actually demo what I was going to show today. So let me know if you can see my screen. Good? Yeah, so we had a committee meeting earlier this month, maybe late last month. And really, we've been working on some of the same projects that we have over the course of the last year or so around the information sharing guide. But one thing that we're interested in from a committee perspective is how we can be more proactive in creating data products that could be useful for the commission or the task forces that serve under the commission. So this was something that we actually discussed in our last meeting. It's a product out of Kentucky from the KY Stats group, which runs their statewide longitudinal data system, similar to my role at MPH here in the state. So a lot of this data we would already have, but I just wanted to show you, it's called their Youth and Young Populations Dashboard. But I think there could be use or benefit if we wanted to replicate in the state, or just look at the possibilities of what we could do with the data. So with the first tab, you're really looking at a regional breakdown of youth populations. They're using a definition in Kentucky of 14 to 24. They're looking at a specific year, 2017 in this case. It's filterable, which I think would be useful for this commission. Whenever we're talking about vulnerable populations, you can filter down to certain subsets of those populations, whether it be low socioeconomic status, corrections, homeless, etc. Everything will display based on these filters, by region, by the percent total of all of your child population. But some of the things that I find interesting or useful might be how they're looking at some outcome data for these individuals. So they move on and they start looking at, since they're starting from a past population of 2017, they're starting to look at how many of these kids in these subsets or of the total population were defined as college or career ready, how many received a CTE certification, graduated high school, etc., all the way through employment outcomes. The other thing that I wanted to show that I thought was particularly interesting in our committee, people thought would be really useful, is I think, for the most part, we understand what our overall youth population look like from these subsets. But something that they've done is they've looked at also, the cross or cross system youth, I guess, or cross sector. So they're looking at the overlap of populations as well. So not just how many are homeless students, how many are homeless students that are low socioeconomic status, and et cetera. Also filterable by the populations as well. But this was just a tool that we kind of stumbled upon. So I wanted to share with the broader commission, so that you have it, so that you can explore it. Right now we're working to scope out what would be possible. But I guess I just also wanted to get thoughts on whether this approach would be helpful for the commission to, start getting some executive buy-in on what would be most useful from our committee in putting together some of these data products. That's it for me. I don't know if there's any questions.
Hey, Tyler, I don't have any questions. I just want to say how much I would love having all of the data all in one place. So I support looking into how we can get this for Indiana.
Great.
Heather, do you have an idea of what the cost would be for the state?
I do not. This was really just, I guess, putting forth and getting kind of the okay to move forward with scoping it out. And our committee's happy to do that. The idea, I guess, would be to use that committee as a kind of a strategic group that kind of looks at how we could break apart the data. But really, I see Management Performance Hub here being a good resource here, just because we have the folks that can build the Tableau dashboards on staff. So there are certain ways that we could mitigate costs.
Is all the data available to you for access to be able to put the report together?
Yeah, everything in this dashboard would be with these categories. I think what we really want to get toward is actually like defining out based on the commission's definition of vulnerable youth, and using this really driven from a commission perspective. But based on these breakdowns, we would.
So I would say if we could get, what would be essential for Director Stigdon to have available, and even Julie, I don't know if you have any input on others that might, maybe our providers or, other people that would like to see this in this type of format.
Yeah, and I agree with what Tyler said. These categories are typical categories that are available in an education data system, and we would need to put it together with, as you said, the DCS data, maybe some other data sets to be able to really show our commission population of interest. And it might be something where we start with what we have and we add over time as we're able to bring in other data sets, right, Tyler?
Correct. And I mean, we could tackle this in waves. Really, this all started out of some conversations in our committee about, we're doing a lot with the individual task force on really specific projects, but how can we almost build out agreed upon populations per the definition of the commission's definition of vulnerable youth, so that we all have the same working logic.
That would be great. All right, Tyler, can you turn this back?
Yep.
And you'll investigate the cost of what that might be and report for our next to Julie, and then maybe she can get it back to the members for approval for future.
Yeah, will do.
And just a note that Senator Bro wrote in the chat, I would love it. I would find this data and this type of representation extremely helpful. And I guess I would add, it also kind of goes along very well with the governor's announcement yesterday that he was going to have MPH start publishing disparities data, because I think we would want any data system we would provide to also show those racial breakdowns. So I think it could potentially dovetail with that project. I don't know, that's for MPH to figure out.
All right, very good. Well, thank you. If there's no other questions, Tyler, thank you. And so moving on would be a strategic priority, mental health and substance abuse with Gretchen Martin. Is Gretchen?
Yes, sir.
There you go.
Hi. Julie, are you doing slides? Okay. Okay. Well, first, thank you everyone for allowing me the opportunity to come talk to you today about the Indiana Statewide Child Fatality Review Committee report on pediatric suicide. I'm going to apologize in advance because there's a lot of information in here and I'm going to go through it really fast. So please stop me if you need clarification, and I'm going to try not to just fire hose you to death with this, but it's going to be pretty quick. So you can go to the next slide. Excuse me. So the Indiana State Child Fatality Review Committee started this statewide review or systemic review of pediatric suicides. We started in 2017, and it took us almost 2 years to get through all of these deaths that occurred in calendar years 2015 and 2016. Next slide. And most of you know, but the Child Fatality Review, for those of you who don't, allows us to look at a child's life course. It allows us to look at any risk factors and protective factors that were in place, any history of trauma, that kind of thing. It allows us to look at service gaps and then identify ways that we can improve conditions or recommend changes to prevent these deaths. Next slide. And this just kind of gives you an overview or a little bit of perspective of where we're at in Indiana. You all may have seen this before, but from 2014 to 18, Indiana historically has seen a consistent number of pediatric suicides until 2018, when that number spiked considerably. And again, when we started this, it was in 2017, so we weren't aware of the spike, but the state committee was aware of the fact that Indiana seems to consistently have a higher rate than the national rate of suicide with our young children. And so we were looking at how can we prevent this? Next slide. When we do these presentations with our local child fatality review teams or external partners, they're a lot of times really shocked to find out that suicide has been the second leading cause of death for kids in Indiana since 2013. So this is a consistent problem. The state committee talked a lot about why this doesn't get, I don't want to say the attention that it deserves, or the recognition or the understanding of the burden of this issue. And a lot of the conversation centered around the fact that maybe it's because these deaths aren't reported in the media, or there's not just generally an awareness of this data. And then also might have to do with the fact there's still a lot of stigma associated with suicide in our culture. Next slide. This just kind of shows you the methods or the information that we gathered where it was available or relevant. And then next slide kind of explains the limitations. So the review process is limited by whatever records we have access to and the completeness of those records. So the more complete the investigation, the better information we have to conduct review and inform prevention. Part of the problem in Indiana is that we don't have a standard process for investigating, and that's for adults or children. And a lot of that has to do, again, with stigma. So a lot of times we run into the fact that a death certifier, especially in smaller communities where everyone knows everyone, they don't want to embarrass, or they don't want to further traumatize a family. So they'll often identify or classify these deaths as an accident or undetermined, so they aren't, further traumatizing the family, or they're sparing their feelings of the family and community. And then also another issue that we run into is, whose job is it really to conduct these reviews? For example, the coroner gets on scene and there's an obvious cause of death, and so their job is to determine cause of death, and so they don't conduct any more of a thorough investigation. Law enforcement arrives and there's no crime that's been committed, so they don't really pursue a comprehensive investigation. And then oftentimes it's not reported to DCS, or it's screened out because there's not a specific allegation of abuse or neglect. And this is no judgment on any of this. It's just kind of where we are. It's nobody's job really to investigate these or gather the information that we really need for prevention. Sorry, one second. Next slide. This shows the selection criteria for our review. We ended up looking at 69 total deaths. We only used those deaths that were determined, or the manner was listed as suicide. We didn't include accident or undetermined. A lot of that had to do with just the time we had and how many cases that would pull in. But just as we look at this, kind of with the understanding that we know we've missed some deaths by suicide that were listed as accident or undetermined. Also of note is that state mortality rates are usually only with residents of Indiana, but we included 2 deaths of children that lived outside of Indiana, but their death occurred in Indiana. And we did that by working with our National Violent Death Reporting System folks in identifying these 2 additional kids. And we included them because child fatality review in Indiana statute indicates that the county or the county or the team where the death incident occurred shall conduct the review. So that's why we included these 2 additional kiddos. Next slide. This just kind of shows you, and most of you know this, but child fatality review is truly a collaborative project locally and at the state level. And these are all of the partners that participated with us on this review of pediatric suicide. So we had a lot of different agencies, a lot of different lenses and perspective looking at these deaths. Next slide. And then our findings, you can go to the next slide. I want to say, I think I saw Dr. Hulvershorn on here, and I just want to point out DMHA was absolutely crucial in this process of conducting this retrospective review. They were able to help us and provide community mental health center information for kiddos that had received treatment through a CMHC. And you can see that almost half of the kids that we reviewed had received prior mental health services from a CMHC. and a smaller percentage, about 24%, were actually receiving mental health care at the time of their death. I will point out that the state team did not look at information with kids who were receiving care through private pay. A lot of that has to do with the fact that we just didn't have the information. So if there's not a thorough investigation, we don't know if they're receiving mental health care. And if they are, we have no idea how to access that information or who they're seeing. And this is just a little kind of a point of the information that we can gather from child fatality review and the qualitative information that we can pull. So we found that at least 2 of these kids that we looked at had issues with that prevented them from receiving mental health care, and that can be insurance issues, family discord, so non-custodial parents who aren't keeping appointments, or non-compliance, as I'm sure you all know, that has to do with a teenager who just flat won't participate in treatment, and the parents often don't have the resources or capacity to understand the severity or how to get that child to participate. Next slide. We also, again, talking about partners, DCS, I saw Director Stigman and Angela on here, Stigman, I'm sorry. We were able to link our case information with Department of Child Service information. And I think you all can read through this, but the thing I want to point out here that was interesting to the state committee as we reviewed this is that very few of these kids, and these categories are, the kids can be listed in multiple categories. So very few of these kids had some formal involvement with either DCS or a court system. So there wasn't a large child welfare or, child system that had touched these kids, honestly, before their death. Next slide. We found, and I'm sure a lot of this isn't going to be new information for you, but asphyxia from hanging and firearm-related deaths were the leading cause of death, and using a firearm was more consistent or occurred more often with older teens. Next slide. We found that the highest number of youth suicides occurred with 17-year-olds. Next slide. We also found that the highest number of suicide completions were found to be in the months of October, September, and February. And this was interesting because it appears to correlate with school year schedules. So these higher count months were also months that kids are in school and could, also correlate with midterms or that kind of thing. And then the lowest incident months occurred during breaks, like summer and winter breaks. And so this relationship is going to be investigated further. The state committee was really interested and want to continue with this process. So we formed kind of a subcommittee of our state team who is going to continue to review these deaths and explore these findings further. Next slide. The time of youth suicide completion we found occurred most often between 5 and 7 p.m. during the week. And so if you use this estimated time of incident, differentiate between whether or not it was a weekday or a weekend, we find that we may have a possible window for prevention where you have older kids who are home alone after school before parents get home during the week. Next slide. We also found that the circumstances and recent life stressors, we looked at all of that for all of these kids that we discussed. And while there were some common circumstances, such as like a note being left or whether the child had talked about suicide, there was not one common way that these deaths were presented. So ultimately, less than half of the youth suicides that we reviewed had even the most common circumstance present. And this information that you're looking at is those deaths that we reviewed that had a death scene investigation and it was documented. So by looking at this and this 2 years of data, suicide prevention isn't as simple as noticing a common circumstance, because over 25% of these kids, this death was completely unexpected. Next slide. And then with recommendations, we grouped our recommendations into 3 categories. So prevention, keeping kids from considering suicide at all, intervention, working to put practice into place after a child expresses ideation or attempt or has a crisis, and then post-vention, the response of the community after a child dies by suicide. Next slide. Handle with care was a big recommendation that the state committee would like to pursue, and that's facilitating the adoption of the Handle with Care program throughout Indiana. What's really great about this program, if you all aren't aware of it, it essentially provides some education to law enforcement and a school system. And so if law enforcement has any contact with a child, whether it's, the child is actively involved in an incident or maybe is asleep upstairs and mom and dad have had an argument or a fight, anytime law enforcement is involved and there's a child involved in that situation, then before the school bell rings the next day, they provide a notice to that school just saying handle with care. So it says Johnny Smith, handle with care. They don't get any other information, but the school system has had some resources or further education that helps them implement a process to provide better care and support to that child. So if Johnny Smith, handle with care, is having a bad day the next day because he's having behavior problems or he's falling asleep during class or he doesn't have his homework, the school is better equipped to provide that support and mitigate the trauma that occurred potentially the night before. So the state committee was very interested in bringing this program to Indiana and getting it going across the state. The next slide, sorry. Also, and I know you all are aware of YRBS, the state committee, one of their recommendations was that schools actively participate in YRBS. Again, because our investigations aren't thorough and complete, we don't have a lot of the information needed for prevention. So if we can get weighted data with our YRBS survey, we might have a lot better information, or I believe we would have a lot better information to inform our prevention. Next slide. Also, the state committee found, and I think that this is going on, or you all may have talked about this, but that a medical home would be a recommendation that came from the state committee. So what we found is that we have a lot of kids that are being released from mental health care or involved in mental health care, and the school system doesn't know, the primary care physician or a pediatrician doesn't know, and so there's not a lot of care coordination that goes on, and so school systems often don't understand or have the knowledge they need to help notice triggers for a child, or parents are getting conflicting information. So just kind of more of a more care coordination with kids would be beneficial. Next slide. Also, post-vention recommendation was better investigations. The state committee talked a lot about how this should happen, and I think there was a lot of consensus on the key steps or the information needed to be collected during a death scene investigation, but there was a lot of, it wasn't as easy to determine who, again, because everybody has their role, coroners, law enforcement, DCS, everybody has their role, and so determining who should do this was a lot more difficult. Next slide. This just kind of shows you, if we had good death scene investigation, the type of information that we could collect from our child death reporting system. So we would have information about not only, what type of weapon was used, but whose weapon was it? How did the child access it? Was it secured? If it wasn't, why not? Or, so it just allows us to better guide our prevention and figure out where we need to provide education. Next slide. And again, this just kind of shows some of the information that we can collect. Again, child fatality review is the only place that we can collect and combine all of this information for prevention. This also does a better job of collecting information about things. We saw a lot of kids when we conducted this review that had texted or used some form of social media to alert a peer that they were considering this. Dying by suicide, but the peers or the friends were afraid, or often didn't let anyone know because they were afraid, their friend would be upset or something like that. So this allows us to collect better information along those lines. Next slide. And again, this is just from the Child Death Review reporting system that allows us to check life stressors about socioeconomic issues, relationship issues, like, you know, was there a fight with a boyfriend or girlfriend, or fight in the family, divorce, that kind of thing. Next slide. And then a post-vention recommendation that the state team was very interested in was supporting the use of psychological autopsies. And this kind of helps that, you know, who is responsible. If we could support and fund psychological autopsies, we would have folks who were certified to conduct these kind of reviews, I guess. It's basically a structured interview with family and friends who knew the decedent and had information about the risk factors and circumstances involved in their life. And they're also able to collect any of the documents and information necessary. So it really provides a really full picture, and especially including the structured interview and the family interview provides a lot of really rich information to help inform prevention. Next slide. And then the next steps for the statewide committee, again, we're going to continue reviewing pediatric suicides because we would really like to have a 5-year trend data and information to be able to share. We're also continuing to participate in the Child Safety Network Learning Collaborative. Although the Child Safety Network Collaborative has ended, our Indiana Suicide Learning Collaborative has continued on, and we're working on resource guides and toolkits to help folks better access evidence-based practices. And we're also going to continue to explore funding opportunities to help support psychological autopsies and Handle with Care program. And then also continuing work with the subcommittees of the commission and how we can better improve our suicide prevention network across Indiana. Next slide. And I think I've talked about all of this. Just, you know, these are some of the things that the state committee hopes that we can implement, are the investigation protocol, Handle with Care, participation with YRBS, and then also that kind of, you know, medical home for the child, the care coordination between agencies and systems. And that is it. Hopefully I did not go over my time. And hopefully that was not a fire hose of information. Thank you.
It wasn't a fire hose, but I guess it was information I didn't have a clue, and I'm sure many here watching maybe didn't have a clue as well. So I really appreciate your efforts in putting that together. Is there any recommendations, or is that our next presenter? Is that going to give us a little bit more of how we can be a little bit more proactive? And I mean, I've had several people in my life that have committed suicide, and it's like, I wish I could have done something different. Is there anything that you feel like, after being kind of engaged here, is there anything that we can do and being proactive to maybe not have to say, I wished I would have done something different? I know that's a tough question, right?
Representative Devon.
Yeah.
This is Chris Naylor from IPAC. And I had a question maybe for Gretchen. Are there good programs or good models to help parents with child internet safety? Because you mentioned the challenges of gathering data on social media and texting. And I saw in the post-vention that was one thing that's very important. But, you know, the idea of suicide clusters is no longer limited to a particular high school or a particular community. It's the World Wide Web, along with cyberbullying. And I know these are just tough things to catch in advance, but I do think the involvement of parents with, you know, knowing what their children are accessing on the internet could help save some lives. I just wonder if there are good models out there.
You know, and I don't know if anyone else has. I'm certainly not an expert in this area. I don't know if Dr. Holvershorn has any information. I can certainly find out. I know that a lot of the conversation from our committee during this review process is how to get the information to parents. A lot of the discussion revolved around schools, and you know that schools a lot of times have a hard time getting parents to be involved and receiving education through that, mechanism. And so I think that it's been kind of a consistent issue from our committee anyway, is even if we have information, how do we get it to the parents and get them to listen to it? So I don't know if anyone else has any information, and I can certainly check further on this and get back to you.
I would just note Christy Berger commenting on a model, common sense, but I would say in terms of the suicide cluster issue, those are pretty rare. So if we were going to do one thing, I would say we would not need to focus on clustering. It would be more about making sure access to mental health care. That's probably the biggest thing take home from me from this work, is half of those kids that died by suicide had not had mental health treatment before. So why is that? Did people not know that they had a mental health problem? Did they not know where to access the treatment? So better screening. We know there are lots of places where folks can go for treatment. We do have a lack of availability of evidence-based practices in those networks, but getting kids into the provider seems to be the biggest gap we have in our state. It seemed like that to me from looking at that data.
This is Senator Bro. I would almost like, and I don't know if I missed this somewhere in the presentation, but I would almost like a similar kind of dashboard that was presented previously about youth to be compiled around the state for suicides and the various ages, and identify if there are certain kinds of trends that kind of go along. Is it high homelessness? Is it high dropout? Is it divorced parents? I mean, are there some factors that contribute in certain areas to increased suicide in young people? Is there some way to compile that data and create a dashboard that gives us a picture of where these suicides are happening and if there are some underlying effects that are contributing to those?
This data brought back memories of being in the emergency department at Riley, and the trends of the kiddos that would come in with suicide ideation matched very well with the data that Gretchen showed. And a lot of things that we saw were testing anxiety. So typically around standardized testing times, finals, midterms, that's when we saw a lot more kids come in. Bullying was a big one, and not getting the support that they needed, whether it was from school or peers or whatever. Social media would come up, the cyberbullying, those kinds of issues. I imagine that it's difficult to gather that information after the fact, even through the psychological, what was that called, Gretchen? The psychological
autopsy.
Because the kids may not share all of that, even in a letter if they leave a note. But there are definite trends that you identify when kids come in and when we're able to intervene when they come in through the emergency department.
So as a legislator, what do we do with this? I mean, this is stark information, I think. And again, I had no idea that suicides are occurring at ages so young. So are there states that are doing something with this data that is being proactive in a way that is interventional or that is preventative, or what do we now do with this data?
I might add that there is already actually a suicide prevention framework developed for the state that a number of stakeholders have come together to work on. And DMHA kind of houses that work. So, I mean, I think there are literally hundreds of things that a state could do to reduce its suicide rate, and a lot of evidence about which things work well and which don't. So it's a complicated discussion, but there are many directions that could be gone in there. Gone down, and that's sort of mapped out in the prevention framework that exists already. That might be a good place to start, I think.
Hey, Julie, just to move forward, and I know, I guess I'd like to give this a lot of independent talking time and to try to move the ball forward in a preventative way. And I don't know how much time we have for this today. Can we clear the screen by chance?
Mm-hmm.
Thank you.
Mm-hmm.
And I don't know if Dr. McCormick, you know, I mean, so when I hear bullying, is there something our schools are doing for anti-bullying and those type of things? So I guess there's, you know, I think we could spend a couple days here talking about this. So I would love to see us being a little bit more proactive and trying to put something together to try to help these kids that are struggling. And if we can, I think with Senator Bro's comments on having data, you know, as far as what's the family background look like, or is it, you know, what's all the details, and, you know, I don't know if we can fix everybody's family issues, but I think, you know, it's a lot of it's broken families as well, I'm sure, but, you know, at least it would be good to have the information.
I mean, one thing that the data, shared that we found in looking at all these cases is the most common theme is actually the presence of a mental illness. So there are family dynamics, there are social stressors like bullying, but in the literature as well as in the Indiana data, the most common predictor is if someone has an untreated mental health problem, mental health disorder. So that is, I think, the central issue is figuring out how to get folks into treatment and get the right treatment and identify that there is a mental health problem. That would account for the majority of the deaths.
And Leslie, is your kind of report on the same line?
Yeah, we got into the specific area of what happens when parents or guardians refuse mental health treatment. So that's a sort of challenging subset of those kids. So that's what the next presentation is about. But I'll also note that suicide, in terms of the commission work, lives within the mental health and addiction task force. So we do have, I mean, there's a number of groups looking at suicide prevention for youth. One of them is within the commission, and we do have some recommendations that could be presented at a future meeting for more global strategies.
So I know last year we had the trauma training bill for teacher preparation, you know, and I don't know if I've not seen that training, so I don't know if that's I'm assuming it's part of what they're looking at. I don't know. I mean, I guess, again, I could go all day long talking about things here. So I don't know if we want to just move to Leslie's report, or does anybody else have any other comments? If not, Gretchen, I really appreciate your report and all that you put into it, and I presented it, so it was a great job.
Thank you very much.
Okay, I'm going to return to screen sharing for the PowerPoint. And I don't know, while I do that, it looked like maybe Dr. McCormick was going to say something on schools. I'm not sure.
I know it was mentioned about schools with their bullying programs. Many of our schools have that part of their totality of social, emotional learning and behavioral type supports. And so we're doing a much better job. Certainly we have room for improvement, but our schools, probably the biggest concern we hear is obviously funding and then access. And I think we're doing a better job of educating and communicating where that access is, regardless of income. So there's a lot going on at the school level, and obviously, again, have room for improvement, but we're doing some pretty good work. Okay, so should I go ahead, Julie?
Yep. Can you see the slides?
Yes, thank
Okay.
you.
Mm-hmm.
Yeah, so I'm the co-chair of the Mental Health and Substance Abuse Task Force on the Commission, along with David Reed from DCS. So I'm going to present work. You can go to the next slide now. That's been done by a number of folks on a subcommittee dedicated to this specific topic, and just wanted to highlight those folks here. Julian Just, a psychiatrist from Riley, also working at DMHA last year, chaired this work, and she was not able to present today. But a number of folks across agencies were really helpful, including some attorneys with some key information here. So next slide, please. So the basic question here comes from the work that Gretchen presented. So, you know, the majority of the cases, this was not present, but it did happen a few times. So the scenario is that a child either tries to kill themselves or states that they are going to kill themselves or maybe someone else. And so that often lands them in an emergency department. This might come to light at school or with a family. The other scenario is that, and we've seen this with a number of deaths actually in Indiana, that a kid might have very severe mental health problems, prominent symptoms for a long time. So they're getting outpatient care. Yet the parent or guardian refuses mental health treatment, either in the emergency room, after they've tried to kill themselves or said that they want to kill themselves, or kind of on an ongoing basis. And I will just note that this is actually a very common challenge in the field of child mental health, that there are many parents who believe that it's sort of optional to follow the recommendations of professionals in this area, or that it's sort of optional to get mental health treatment. I think this is more of a problem than, say, like cancer or other, medical specialties where families tend to kind of defer to the experts. So this is a common problem, but we're really just talking about those scenarios where it's very clear that there's an immediate risk or an immediate high level of harm. Yet the guardians or parents are not willing to follow the guidance of, say, a psychiatrist or whoever they're seeing in the emergency department. And again, this is not something, this level of severity does not happen all the time. This is a fairly rare scenario. I would say in my 10 years of practice in the state, I've probably been aware of maybe 10 or so examples of this. So it's not every day that this happens. So the question, though, is what should be done for this child in this instance where the adults in their lives are not in favor of getting them services? And you might say, well, why aren't these adults getting them services? It's hard to say. Sometimes it's just a really challenging thing for a parent to psychologically cope with, right? That their kid wants to hurt themselves. It's just so hard to believe. There's a lot of denial. So sometimes, that it's as simple as that. Other times it's a lack of trust of the system. I don't want my kid hospitalized. I don't want them taken away from me, or just, I can't believe this is happening. This isn't possible. My kid would never do this, that kind of thing. So what should be done, though, in the moment? Should DCS be involved? Should forced treatment via the emergency detention or involuntary commitment route be used? All of these are challenging. And so what this group did was kind of figured out, well, where are the problems occurring in this process? Next slide, please. And what are some recommendations? So if we were going down the involuntary treatment route, so this is in place in Indiana, typically used for adults. So for example, if an adult says, I'm going to kill myself, and walks into an emergency room, there's a legal basis for a physician to sign an order and fax to the judge that this person is being treated and assessed against their will. So the problem with that is the statutes are not, and it's called civil commitment, are not actually explicit about how they apply to kids, to minors. There are some sections that kind of hint, though, that juvenile courts can be involved. So the assumption by our legal experts working in this area is that this is appropriate for use in kids. The problem is it's not something that's widely used around the state for kids. It's used very rarely. So it does give the physician an authority to detain a person for 72 hours. We call that emergency detention. And then they do have the option, if that person needs ongoing forced treatment after the 72-hour mark, to petition. So that's the kind of the problem is providers don't use this for kids often. They're unaware that this is appropriate, and it's unclear kind of how judges feel about this either. I mean, what would happen if a bunch of kids started showing up? And again, this is not something we think will happen often, but we do think it might be underutilized. Next slide, please. So our recommendations here are that we should support some educational efforts to make mental health clinicians, hoping perhaps DMHA or mental health advocates could play a role here, and as well loop in judges to make sure they are also on board and aware of what's written in the law currently about utilizing this commitment approach or emergency detention approach, because we know that it's underutilized for adults, but we suspect it's also underutilized for kids in these kind of scenarios where the guardians are not, allowing mental health treatment to happen. Our group also thought that it might be helpful for mental health facilities to have documentation that they could share with parents and guardians so they would understand very clearly what the processes are. So I think a lot of families don't realize, you know, hey, if I say no to this admission, you're going to basically get the courts involved, you know, and that's a pretty big step, and make sure they're fully aware of what's going on and what the process is, because there is no such documentation widely used at present. And this is not a recommendation, but just, you know, someone was asking earlier, what could legislators do? We're not saying do this. It's just one thought would be that, you know, it is possible that the commitment statutes could be more clearly written so that it is clear that juveniles, that they absolutely apply to juveniles. And in other states, that is often the case, that there's developmentally appropriate language around in there. So I don't know if I should just pause here, because this is one of the topics, and we're moving on to several others, if there's comments or questions on that in this specific topic. Okay.
Representative Devine.
Can move on then. Oh, yeah.
Yes, go ahead.
Yeah, thanks. Chris Naylor from IPAC. Dr. Holvershorn, would there be a need to clarify how this is paid for, this involuntary treatment for juveniles, whether it be, you know, the courts, a county general fund, or DCS? Is there a need to clear that up?
I mean, I think there's always that issue with commitment, who pays for it. I don't know if that's I don't think that's a barrier here. I don't think that's the reason why we're not seeing it utilized. Director Stigdon, did you want to comment on that?
That's not the barrier. I've seen it used, like you said, it's really rare for it to be used, but payment is not the issue. It's the comfort level of doing it, and whether or not it's the comfort level of the physician to be able to do it, and whether or not it's legal to do it. It's uncomfortable to say that a child, we're going to detain them. Clarifying the language, I think, would be helpful, but I don't see money as a barrier.
I didn't know if the Chief Justice had any comments. I don't want to put her on the spot either, but.
So this is Senator Bro. Maybe if clarifying the language is something that would be helpful, if perhaps that's something maybe Julie could work on as part of this project.
I want to just answer that quickly too, that I do not see this used very frequently in the juvenile area, but I agree with Director Stigdon. I mean, between Medicaid, emergency, DCS fund, I mean, I think that there are some funding avenues available. I don't think, I mean, I think it's getting them to court, they're getting the issue to court, even knowing that court's an option in the middle of this crisis. So it's kind of looking at the medical legal partnerships and educating medical providers with regard to this being an option for families as they're counseling that family when that family's in the moments of crisis, maybe after a suicide attempt.
Yeah, I have seen a couple of instances where a family refused treatment because they had a high deductible insurance plan. And these are kind of the bane of our existence in child mental health now, because if a family, you know, the $5,000 deductible and this admission is going to cost, you know, $5,000, you know, it can feel overwhelming to families to think about that expense. So there are instances where I think it comes up, the financial issue, but for the most part, you know, the payers handle everything. I mean, these admissions are covered by insurance. It's just the high deductible is where things can get dicey sometimes.
Any other questions or concerns? If not, Doctor, you want to move forward?
Again, but this is Senator Bro. I was just asking if there's that clarifying language, if that's something that's important, that if there's a way to maybe get that done.
Perhaps, Dr. Halvershorn, your committee could actually produce a red line of the current code as a recommendation and bring that to the next meeting.
Yeah, I think we could ask our attorneys to help us with that are working on this issue. Mm-hmm. Yeah. Okay, make a note of that. Okay, so yeah, so those are the recommendations there. So yeah, so there's two recommendations, one optional thing for legislation, but it sounds like there's interest in learning more about what that legislation could look like. So moving on away from the involuntary treatment concept is the other issue is, is this something that actually is ever substantiated in Indiana in terms of when it's reported to DCS? So when the parent or the guardian refuses or is non-compliant with the mental health care, it's clear that that is a reportable issue, right? So there's the mandated reporter training makes that very clear, as well as other documents. But it's not clear how often this is substantiated. So the group, requested data about, how often do these cases actually get followed through on, and for that we just don't have data. So what we discovered is at least what we were told, we could not find data about this issue specifically. But the clinicians that were on the committee reported that they have not found that these cases are actually substantiated as being neglectful. And the attorneys from DCS said there are a number of reasons for that which we can kind of get into, but they're reluctant to take those cases to court. So I think a starting point would be to try to understand more about what, how often this happens, and if it is, not substantiated, why is that? As a side note, Illinois, there was a publication in a hospital journal from Illinois saying that over a 6-year period from Lurie Children's Hospital in the Northwestern hospital system, most of the cases that were reported to their state welfare agency did not involve mental health neglect. So it's probably a very rare report. Only 4 of 156 cases in this particular paper reported that. So we have no idea how often they're reported and then how often they're founded. So, but we do know that the category that the child would fall into in terms of CHINs would be a CHIN 6, and we do know that we believe there are very low rates of CHIN 6 utilized in Indiana, and that's the child substantially endangers his or her own health or the health of another individual category. So, you can go to the next slide, please. So the recommendation here is just to understand more about what data is available. And so the folks on our committee from DCS said that currently there is no kind of way to categorize in the DCS database whether or not mental health neglect or substance use treatment neglect was part of the story or part of the reason why the child was referred. So our recommendation is that DCS start to code that so that we can know more about this particular kind of situation, and then, eventually be able to say, okay, we had, 10 cases reported last year, 5 of them, were found to be substantiated, or none of them were. I mean, that would tell us kind of more about where the issue, where the underutilization or overutilization or whatever it is happening. But for now, we just don't have the data to know. We also heard from our colleagues at DCS that the folks who answer the phone when cases are being reported for neglect probably don't have the line of questioning that would allow them to be able to really pull this kind of information out like the attorneys would need, is what the attorney said, to be able to substantiate the case or recommend further investigation. So the recommendation here again would be that DCS would develop
I can't hear you, Leslie.
For this issue, for when the case is reported to the child welfare agency. Comments on this? Questions before we move on to the last one?
Anybody? Terry? Dr. Stiglin? Sorry, Director.
No,
All
I
right,
don't
let's
have
move
any
on.
questions.
Oh, there
Thanks.
she is.
Okay, and I guess, this is very anecdotal, but in my experience, of the 10 cases I mentioned earlier that I was aware of, all of them were reported to DCS and none of them were, the child went home with the parent in all 10 cases. So I don't know if that's always the case, but that's been my experience, and that was kind of the experience of other folks, other clinicians in the area. So And I should say as an aside, if we look at national recommendations from, American Academy of Pediatrics, American Academy of Child Psychiatry, they all recommend involving both the Child Welfare Agency of the state as well as the petitioning the court for forced treatment. If the idea here is there are kids who are neglected in terms of their mental health care, and we have to utilize both systems. So it's not an either or. Okay, next slide, please. So the other thing that came up, which was interesting, the attorneys that were specifically working in this space in DCS said that it's hard for them sometimes, if they did have all the information they need, to make the case in court around mental health neglect, because mental health neglect is not specifically defined as part of child neglect or abuse. I mean, you can extrapolate that it must be relevant, but there's nothing that specifically says if a child is not given mental health treatment, that's neglectful. So we did not want to go as far as to say this must be fixed, but this is another consideration for legislators to think about writing Indiana code. And there are national definitions of what mental health neglect means. I mean, it basically means withholding mental health treatment or withholding substance use disorder treatment for somebody who needs it, and not because that person doesn't want it necessarily, but because others around them don't feel that they need it or whatnot. But my understanding from the attorneys is this can sometimes be a hard case to make in court in Indiana due to this issue. And I think that's the last slide.
I guess I'd leave that up to the courts to determine if we need a necessary change in legislation. I don't know.
Yeah, so when you say it's a hard case to make, is that because there's no documentation showing that mental health services were refused or denied?
No, I think they mean it's a hard case to make because the language that the judges would use from the Indiana Code does not specifically outline mental health neglect as clearly being neglect. I think it is also a harder case to make, though, in terms of mental health neglect than it is like medical neglect, for example. So that, it's a little more subjective in the field of mental health. So the attorney said, you might need multiple psychiatrists to weigh in, for example, rather than just one. So it is a harder case to make also for that reason, too.
Okay. Okay. Well, yeah, I would be with Representative Devon on that one. Let's let the attorneys kind of figure out where that language needs to be tightened in order to make it more effective for them to get to be able to use the information.
Any other comments or questions? All right, Doctor, thank you for your report and putting that together.
Yeah, thanks for having me. Okay,
it looks like we're pretty close to maybe even a little ahead of schedule here, so that's amazing in itself. Strategic priority, child health and safety. Sharon Pierce.
There. Thanks so much, Chairman Devon, and all of you. And truly, as somebody who's worked passionately in child and family services for decades in Indiana, I am so excited about the continued commitment and work of the Commission to see state agency leadership coming together on behalf of our most vulnerable children is just heartwarming. We've talked about some really very concerning situations for our children. I think Angela and I are blessed because we get to talk a little bit about what I call the silver linings amidst all of these challenges that we're facing, and about some folks who are standing in the gap. And this is a true partnership to look at what our kinship caregivers, those relatives, grandparents, aunts, uncles, brothers, sisters, who are raising children in their family circle, need from us as a state to be successful and to help those children reach their full potential. And just want to acknowledge that Dan Cowan is one of the senior strategic consultants from Casey Family Programs. Director Terry Stigdon and Assistant Deputy Director Angela Smith-Grossman have been wonderful partners in this process. This really is a true partnership. Next slide, please, Julie. You know, we don't know exactly how many kinship caregivers we have in Indiana. We know there are around 18,000 who are documented in terms of that formal role of being a kinship caregiver. But folks think there could be upwards of 80,000, 100,000. You know, folks just stand in the gap, and that's who we're talking about today. The Villages has had a program for 18 years now. I was thinking this morning driving to the office that we have come of age. We're of legal age, started in 2002. But our youngest caregiver today is 30 years of age, but started working with our Villages Family Connection Network program when she was 23, taking in her younger brother. And then our oldest kinship caregivers right now that are working with us are an 82-year-old grandmother and grandfather who are raising 4-year-old great-grandchildren, a boy and a girl, twins, one of whom has cerebral palsy. So at the end of today, when you think you're tired, just think of that 82-year-old couple that is probably still checking on that little guy. It's the boy who has CP. And that little girl to make sure they're sound asleep and then just falling into bed. We really wanted to talk with you today, next slide, about something that we've already been able to accomplish on behalf of the Commission. One of our priorities has been establishing a statewide kinship care advisory committee with those lived experience voices of kinship caregivers. And some of them talked about how difficult it is for them to find the legal support that they need. Many of our metro areas like Indianapolis, Fort Wayne, Gary, Evansville have a bar association group or a legal services group that's able to help folks, but one of the great resources that we have in Indiana is an Indiana Legal Access website. And Kate Guerrero of that, who provides consultants to that group, has just been a phenomenal resource. So we have now available Indiana's legal guardianship forms with the instructions on our Indiana Legal Help website. And we want you to help us spread the word. September coming up is Kinship Care Appreciation Month nationally. And one of the things we're going to do throughout that month is make sure that all of our colleagues who are working within the public sector, the private sector, the faith-based sector, and community organizations who might be serving or supporting a grandparent or a relative who's raising the children in their family circle know about this resource. So I know that you all have a long to-do list, and I just want to congratulate you and all of us that we can check this off as something that we've done. Julie, next slide, if you will. The other action step that we've accomplished, and this was something that Dan Cowan from Casey Family Services really was promoting, was that creation of a statewide kinship care advisory committee. And this is a phenomenal group. It is, again, a commitment of the public and private sector. We have our Region 7 DCS leaders who are working on a pilot project that Angela will talk with you about. A variety of kinship caregivers. Again, I think the age range on the statewide advisory committee is 30 to about 76 years of age, so many intergenerational issues. And we always provide the kinship caregivers with a gift card for gasoline, as well as a gift card for a meal or two for their family, because we feel strongly that we need to acknowledge their time and their professionalism. Next slide, Julie. This group meets quarterly. They'll be meeting again in September, and we'll really be celebrating them since that is Kinship Care Appreciation Month. I mentioned that we provide support for them, and their insight has just been invaluable. One of the things that they are most anxious about is having our state, having fellow citizens, having fellow community members understand their role. And repeatedly they said, you know, people get what foster parents do. People understand what adoptive parents do, but nobody understands what I do as a kinship caregiver. And so that's really a part of our focus for this September's Kinship Care Appreciation Month and beyond. And again, you all can help us with that in conversations, letting folks know that these are folks who truly are standing in the gap, keeping children from the DCS formal child welfare system and keeping them within their own family circle. And the research is very clear. Director Stigdon would be the first to tell you this, that that's where they belong if they can safely be within their family circle. You know, the outcomes, the stability, and the permanency are just stronger for children. I want to hand it off to Angela Smith-Grossman, who's the Assistant Deputy Director at DCS. And Angela, why don't you update us on many of the DCS initiatives?
Thank you, Sharon. So I wanted to provide a bit of a summary for where Indiana has been with the Kinship Navigation Grant. So we are completing the second year cycle from the federal government of a grant that was given to Indiana to establish a kinship care navigation program. The first year we spent a pretty considerable amount of time building the DCS infrastructure, writing program, training the staff that would be executing it, and preparing to implement. As Sharon already mentioned, we implemented the pilot in Region 7. Essentially what the pilot is a series of case management supports and assessments that we provide internally to DCS Kinship while we're concurrently establishing resources within a community to support kin long-term, either outside of DCS custody or post-DCS custody. Year 2 has been spent in doing our formal evaluation with Indiana University to determine if our program may become eligible as a promising practice, an evidence-based practice for Families First Prevention Service Act, the federal preparation that we're doing for Indiana DCS family-centered practices. So that's been primarily the kinship navigation grant work. We have been awarded a third-year cycle. Our third-year cycle now will really start the emphasis externally to DCS. We are seeking to establish some more targeted support groups across Indiana to provide targeted, relative-focused support networks that are very similar to villages, in the hopes that the programming and the types of service array that the villages has provided to central Indiana might be something that's replicated across Indiana. As Sharon also mentioned, we have a series of events both internally and externally to DCS that are to mark the celebration or the acknowledgement and awareness of kinship as a national month of recognition. We have some brochures and materials that are being paid for out of our grant that we're going to be distributing to our community partners for child safety providers across the state, to 211 and to other external partners. The other fascinating thing that has really happened in the course of the last 6 months is really the opportunity to engage differently with the community. We have several different pilots that have occurred with different faith-based communities in different pockets of Indiana. We've had several churches as well as some school corporations that have stepped up and engaged with our staff to provide needs, whether that was backpacks for returning to school or food resources. We've been able to reach nearly 1,000 different relative families across the state in those types of activities. Sort of the community being drawn together during this time has allowed us some unique opportunities to establish more long-term relationships in the hopes to fill those gaps. We hope to have some of our final evaluation done here in Region 7, and we have also then initiated some of the components in all the other regions. So we have targeted Lake County. We have a partnership presently that is with our assistant deputy director up there. She's involved in a minority project through Adopt Us Kids that she's focusing on increasing kinship in children of color populations. And so she's been able to help us, and we in turn then have rolled out our kinship navigation pilot to Region 1. So that's pretty exciting. We also, in August 1st, we rolled out the crisis component of the model to the rest of the state. So we are moving forward even before we have the final information from our evaluation, because within DCS, Region 7 continues to show the highest density of kinship placement of any other region in the state. A lot of that can be the leadership within that area that has emphasized the kinship relationship to families and to wellness. But some of that is certainly the pilot program that we have that's bringing attention to the kinship that we serve. So those are just a few things. There are some really wonderful organizations that have stepped forward within central Indiana, such as iTown Church, that continues to be a great partner to us. And we've also had some activities in some of the other areas with Easter baskets, spring information for families. We've certainly recognized a high need for educational support for these families during the virtual existence in schools. Our families seem to struggle considerably because they are often not eligible for childcare subsidies. Current CCDF requires that the income of relatives is counted towards their eligibility, which then excludes a lot of them from that partnership that we have as well. So that's another area of opportunity, continuing to support the schools in the identification of these families so that additional educational supports can be given is another important aspect. Also, when we are thinking about what we might do in terms of next steps, is there is a considerable amount of research that indicates that supporting strong mental health components for these families long-term is beneficial. So I appreciate the previous presentation that really advocates for Indiana to make sure that our youth are getting their mental health needs met, because that is also something that shows some considerable long-term opportunities. Most of our families continue to access TANF and SNAP as their primary financial support. One final thing that Indiana is doing is that we are starting to look at some of our statistics in terms of the rates of placement within DCS and really just in the demographics outside DCS of racial inequities that might be something else that we can target as some opportunities. So we are designing some educational materials for our staff and our partners to start considering some of the barriers that our families meet that are unique to populations of color. So that's pretty much what we're doing. And if there's any questions, I'm happy to take any of that.
Thanks, loads, Angela. And as Angela
I do.
said, I think for all of us engaged in this, this is a passion of equity a commitment as well. And with the data being so clear, if you want to go to the next slide there, Julie, about you know, the stability that family caregivers, kinship caregivers provide. As Angela said, one of the grave concerns right now is that e-learning challenge. And I know for our kinship caregivers and many of our foster families, we are creating some e-learning labs and getting the place sanitized and getting some partitions, and have had some wonderful donors step up with hotspots, computer labs, because we don't want these stable family settings to disintegrate because of the pressure and the stress really that e-learning can provide, particularly for those who are 2 or 3 generations removed from the technology that's allowing us all to meet today. We're having virtual support groups every month, and one of the things we've tried to develop is what I call a covenant between us and those kinship caregivers, that we are providing lots of support, the porch pantries, you know, gift cards, those kinds of things. But we want to create a peer community for these kinship caregivers. Certainly we know the value that that provides for foster parents, and it's important that kinship caregivers have that same opportunity. And as Angela mentioned, the Families First Prevention Services Act, I think, is going to provide us with even greater opportunities to be intentional with resources for these families. And Julie, if you want to just share the next slide, I always love to put the face on those that we're privileged to serve. The young man in the left-hand corner, Joseph, is the gentleman that's being raised by his older sister. And she always jokes about the fact that she's not missing bingo in the church basement like most of the kinship caregivers. She's missing the dating scene because she's the one who started this when she was 23 years of age. And so just this week, Joseph received his driver's license, and it was quite the celebration. And lower you have a grandma. She is 81 herself, and she has 4 children in her home, and they wanted to take the picture of her because they'd never seen her in a hat. We had a virtual hat night as one of our virtual celebrations. We had an early Halloween celebration, and you can see a grandma and a grandchild. What do I want to be when I grow up? Adriana down in the far right corner wants to be a hairdresser just like her Aunt Sally. So these are folks that we have come to love, and they represent, you know, thousands of dedicated caregivers throughout the state. So we just thank you for the privilege of kind of sharing with you a little bit of a snapshot of who these amazing folks are. They are selfless. They don't ask for anything, but they need our help in navigating. And as Angela used that word, the navigation, kinship navigator process, that's exactly what we're trying to help them do. But again, just to remind you all, one of the things that we wanted to do was create that statewide advisory committee and create the legal access for the guardianship forms, and you can check both of those and pat yourself on the back for accomplishing something. So thanks loads. As Angela said, we'd be happy to answer any questions that any of you have.
I know Vanessa, Representative Summers had a question.
I want to thank you so much for as much as you've done so far for the kinship families, but I'm still concerned about you said that you don't know if there's some 80,000 families that are taking care of kids. And I guess my issue is there ever going to be a way that we could come up with financial help for them? How first can we identify them? And again, I guess my one question, are these families that have gone through the foster care system, or are they just kinship care people that have taken their kids in? Because if they've gone through the foster care system, then we still have probably that 80,000 that you suggested that are out there bumbling along by themselves without any help. So is there any marketing we could do? Because I think that you would see that your numbers would go up substantially if some people have their heads down taking care of what they have to take care of. And that's what we do. You know, I agree, that's what we do. But if they knew, if they could stick their head up and know that there is some help. So those are my questions, especially the one between the foster care and the non-foster care. Because the non-foster care that have the children are the ones that are not getting any help and that are helping the state's numbers go down because they're taking their children in. And I still think that that's a hardship on those that are probably lower income minority that are trying. And I need to see that those people are also getting some help. Because before it was that, okay, if they go through the foster care system, then we have all this for you. So that's kind of where I'm at.
Let me share with you the Villages program. 92% of the families that we're serving are informal. So they've chosen not to go through the foster care system. And I think you're exactly right. It is frustrating not to know exactly who's doing that. I think that's one of the reasons why Angela and I are so excited about those community partnerships, because that then broadens the safety net. The other reality is that the Families First Prevention Services Act will really allow us to be much more intentional, both in counting those families as we serve them and providing some of those financial resources. So, and Angela, you want to chime in, or Director Stigdon as well, please?
Yeah, so one of the things that if our model is considered to be an evidence-based practice, then there can be some federal reimbursement around the staff and the services that are delivered as a part of that. So that's a really important component of our kinship navigation grant, even though that's internal to DCS. There's no guarantee that we're going to rise to that level, but that's the point of doing the model itself. The other thing is that we have run a guardianship committee that's been running concurrently to some of the kinship issues, where we identified that there's somewhat of an underutilization of guardianship assistance programs. So for the families that do come through DCS, that helping those families understand that program, but also access that that money that's there for post-case support. And so we have some efforts internally to help change the tide on that, as well as we've done some fiscal impact information to make some suggestions and recommendations about changes. But a lot of that has to do with, obviously our current economic climate is somewhat of an imposition to expanding certain programming. So we are trying to make sure that we leverage what does exist in a higher intensity way. So I hear what you're saying is that we don't have great data on the families that are outside of DCS that might need support. Many of those are temporary and not always long-term, which even complicates it further. But we believe that our best option is to partner in the local regions with those agencies that are already serving families and help them identify how kinship families are different and unique and might need some additional supports. So that's the effort as we kind of push out into this new grant year that we're really going to be making with the Community Partners for Child Safety, which is already a contracted set of providers that help provide case management and concrete supports to families in the communities where they live. So hopefully that will satisfy some more of those efforts that you're speaking with, Representative Summers.
And also, Angela, too, I think our push in September is that awareness raising. We're going to be trying to drive folks who work with families as well as the families themselves to the resources. And that was the clear message that we got from the kinship caregivers who have been a part of our advisory committee. The resources may be out there, but we don't know about them. And so we've taken that very personally and very passionately. So that's just kind of the beginning of a kickoff to be much more visible about, number one, who these selfless caregivers are and the important role they're playing in our state, but number two, where they can go to get some support. Don't you think, Angela?
Yes, yes.
Thank you.
And Sharon, if anybody else had any more questions or concerns, I know we're running a little behind now, and I'd like to make sure that anybody gets their concerns, they can just reach out to you or to Angela direct or.
Absolutely.
Just Representative Devon, just one plug for the census
Yes.
2020 and looking at child living arrangements, and as much as we can get information out there for people to complete the census survey, then we'll have better information as a state on how many children are living with kin, because there are kinship reports that don't give specific household information, but we have a better idea of the numbers that we're talking about, Representative Summers.
Thank you. All right, next, and I apologize for pressing a little bit, but I'd like to move forward with Amanda Lopez and Margaret Smith and Transforming Consulting presentation.
Hi, thank you for having us today. My name is Margaret Smith. My colleague Amanda Lopez is not able to join us this morning, but I'm happy to provide you with a brief update this morning on the strategic framework for prevention of child abuse and neglect. So I work for Transform Consulting Group, who's the primary contractor with DCS that is leading the development of this strategic framework. And we're most excited to share this update with all of you today because, as many of you know, this project really came about as a result of the recommendation made by the Commission. So Julie, if you want to progress to the next slide. I first want to start by lifting up our key partners and subcontractors who are really crucial and integral to this process and this project. So first, the Villages and Prevent Child Abuse Indiana are serving as really important subject matter experts in this area. So I know you just heard from Sharon, and we're working with her very closely and are grateful for all of the expertise that she's providing. Another key partner here is the Indiana Minority Health Coalition. who will play a key role this fall in going out to pilot communities to collect feedback from communities across the state on this framework and on its components and on what families and communities really need in terms of enhancing their prevention efforts. And then the remaining partners there, Herd Strategies and Jam Printing, will help with the development of the framework and toolkit documents and printing all of those documents for dissemination. So Julie, you can progress on, thank you. So with this project, our key goals are first to increase the effectiveness and alignment, as well as the coordination of existing child maltreatment prevention efforts across the state, while also identifying new opportunities to support children and families, and specifically to promote the resilience and well-being of those families and children while decreasing the incidence of child maltreatment. Go ahead, Julie. And so as part of this project and reaching those key goals, we're working towards 2 deliverables. So the first would be a statewide strategic framework that includes agreed upon values, a vision statement, outcomes, indicators, and some actionable strategies for communities to utilize. And then with that framework, we'll have an accompanying toolkit that provides local communities some guidance and resources where they can innovate this framework and tailor it to meet their community's needs and the needs of the families that they aim to serve. Go ahead, Julie. And as many of you know, when this recommendation was first under consideration by the Commission, a work group or subcommittee was formed to look at similar efforts in other states. And one of the states that the subcommittee looked into was Colorado. And so I wanted to share this example. This is kind of the finished product in Colorado of the strategic framework that they developed. And so I wanted to highlight this example because I know when we talk about this type of framework, it often seems very abstract. And so I think this concrete example explains a little bit better what our end product will look like. So you'll see that I know it might be a little hard to see on the screen here, but their framework includes a vision statement, foundational principles that are similar to the values that we're looking at in our development, as well as those actionable strategies or what they call channels for change, and then overarching outcomes that would be able to identify key indicators under those to measure progress and success, both at the community and state level. Go ahead, Julie. And so that's kind of the end product that we're working towards. To reach the development of that framework and the accompanying toolkit, here's kind of our general outline and timeline for the project that we're looking at. So we kicked off with the Department of Child Services in April, and between April and September of 2020, our goals were really to convene a statewide stakeholder group across sectors to really bring representatives from across the state to help inform this process and the development of the framework and toolkit. And so as part of convening that group, we're hoping to identify values, outcomes, and all of those key components of the framework that I mentioned a moment ago. And then from that, we will create a draft framework as well as stakeholder feedback tools so that we can pilot this framework and toolkit later this fall in some pilot communities across the state. And so that's another goal here coming up in September, is to finalize those pilot communities. So we're looking to identify 3 to 6 counties or communities across the state to pilot this framework and also to get feedback from families and communities of the needs of our state and of families in our state. And then in October and January, that's when that feedback is really happening in the pilot communities. So we'll be reaching out to parent groups as well as other community stakeholders to get feedback on the initial draft framework. And in that time, we'll also be kind of refining and finalizing the framework and the strategies that we want to present to the statewide stakeholder team. And then in January, we'll come back with all of this rich stakeholder feedback and the updated drafted framework and have a planning retreat with that group along with some local representatives from the pilot communities to really fine tune and refine the framework and the accompanying toolkit so that we can work in February to June of 2021 to create kind of the finalized product that we can then disseminate next summer. Go ahead, Julie. And so a current status update for where we currently are. We did convene that statewide stakeholder group, or what we're calling the statewide advisory team. Our first meeting was back in June, and that team is comprised of 24 members from across the state, and they represent the following sectors that you can see on your screen here. So again, our goal was to really find members and find key individuals to represent those cross-sector groups that we wanted to really further these efforts. And so again, those state government agencies, prevention and mental health partners, education partners, philanthropy partners, and then several other community organizations. And so our next steps here, we will be reconvening that statewide advisory team next week, so August 25th. And from that input that we receive from them again, we'll be creating a preliminary draft of the framework, and then this fall going out to the pilot communities once they're finalized and selected to get some feedback on all of these tools and on the framework draft. And so I know we're a little bit behind time. I don't know if I can take questions at this time. If not, feel free to reach out to myself or my colleague, Amanda Lopez. Our contact information is there on the screen. And thanks again for having me today. Do we have time to take any questions, or would you prefer folks reach out to us directly?
We'll take just one or two real quick ones if we can, and then, but I don't want to short. All right, well, thank you for that report as well, and to all those that have been very informative. And I feel like we're kind of rushing it, but at the same time, I know it's so critical, and I don't want to, and I appreciate everybody's work as well. But so next we'll move forward to Christy Berger with the Indiana Department of Education.
Great, can you all hear me fine? Hear me good? Okay, great. So I'm Christy Berger. I'm the Director of Social Emotional Behavior Wellness for the Indiana Department of Education, and wanted to come today just to share the work that my team has been doing to support educators in the field. So thankful for Dr. Holbershorn and Gretchen's presentations, as I believe this really tees up well what the work we're doing and why we've been doing that work over the past few years since Dr. McCormick has been in office. So Julie, you can go ahead and go to the next slide. So I always just like to start my presentations with data, right? Data speaks. I'm not going to read all of these to you all, but some that I would like to point out is that we know from the IYI Kid Count Data book from 2020 that Black students are 4 times more likely to receive out-of-school suspensions than their white peers. 1 out of 3 high school students reported feeling sad or hopeless in 2018, which I think directly ties to all of the work that was being done in the suicide prevention. And being a school counselor 10 years before coming to the field, I saw this every day with my middle school students. I assess students for suicidal thoughts and suicidal feelings, and we're still seeing year after year that our students are feeling this way. And almost 26% of Hoosier high school students don't feel safe at school, whether that be bullying, whether that be racial tension, whether that be violence or school shootings. 26% of our high school students don't feel safe. And so I'm not gonna, like I said, I'm not gonna read all of these to you, but I really think it's important just to hear what our students are saying to us and then how they go hand in hand with the national data, Julie, which is the next slide. And I wanted to point these 4 out that at the age of 13, 20% of our students are diagnosed with mental health disorders, and 5% of our adolescents are diagnosed with substance abuse disorder. And all of those go hand in hand with school attendance. So students who struggle with mental health concerns, we see a chronic absenteeism, which is missing 10% of their school year, and it's tied back to these mental health concerns. And youth are 6 times more likely to complete school offered treatment. So having a mental health provider in the school that can help provide supports outside of the school counselor, school social worker, this is an additional support that that student and their family can receive. So when we talk about social emotional learning, we really look at the definition that CASEL, which is the National Organization for Social Emotional Learning, put out 20 to 25 years ago. And what we're talking about are skills that we want our students and adults to be able to do. So this learning is never done. They get it in elementary school, they need it in middle school, and they need it in high school, and we need it as adults, right? And so we're looking at how to understand and manage emotions, set and achieve positive goals, establish and maintain positive relationships, feel and show empathy for others, and make responsible decisions. Social emotional learning really is a preventative tool for suicide prevention, bullying prevention, substance abuse prevention. It really helps to help students have that prevention piece, but also learn the skills that are needed after high school, whatever that may be, college, career, or military. So we can move on to the next. The benefits of social emotional learning. So for every dollar that is spent in a school system, you will see the rate of investment back to the community being $11. So that is because we're seeing less students needing medical supports, mental health supports, juvenile supports. Those types of numbers are decreasing as the social emotional learning programming increases in the schools. Social emotional learning has its best impact when it begins in kindergarten, because like I said, it's a continuum and it's skills that our students continually need to go on throughout their lifehood. And we see an increase in their student academics by 11%. So those students who are receiving social emotional learning with Fidelity, they will see an 11% academic gain on their state test. And then not only does it have a positive effect for our students, but also on our teachers and our educators in the building, as it helps with their stress levels, it helps with their excitement to come to work, and it helps build community within the school. Next slide, Julie. A lot of myths that we hear about social emotional learning is that it's touchy-feely, it's only for elementary students, we're talking about morals and values, it should only be done at home, and that it's only for students with behavior and discipline problems. And the data truly links to show that these are just myths. While social emotional learning does talk about feelings, it also talks about cognitive reasoning, it talks about employability skills, it talks about conflict management. How do I handle another peer? How do I handle an adult when I'm in the business world? So these are skills that all students need to be successful when they leave our K-12 space. So Indiana created our own competencies 2 years ago. We partnered with 2 professors out of Butler to create these, and you'll see CASTLE, which is the wheel. They've been around for 25 years, and inside that wheel are their 5 social emotional learning competencies, which we took and embedded into our work. But we added mindset and we added sensory motor integration, because there's been a lot of research in the past 20 years that shows how our students' brains are developing and ways that we can support that development and help to rewire some negative thoughts and negative feelings for those students. So just wanted to point out again that social emotional learning ties really closely with that college and career readiness, which we know Indiana believes and is working hard to support that workforce development. In 2020, this is what employers were saying that they need from their employees. They can teach them the content, they can teach them those skills, but they need to know that their students can critically, or excuse me, their employees can critically think, can manage people, can coordinate with others, and are able really just to problem solve. And so that is where we as schools, K-12, need to be investing social emotional learning into the academic day so that they have those skills when they leave our space. So social emotional learning and school mental health sometimes gets really intertwined and seen as the same thing. It is very different, but they do go hand in hand. So when Dr. Holbershoorn is talking about mental health diagnosis, that's not social emotional learning, that's mental health, and that supports in that space. Social emotional learning, again, is that preventative tool for mental health. It does not mean that a student won't struggle with mental health. It just helps to reduce the likelihood of them having a mental health concern. Social emotional learning also helps to really teach students how to handle stress, relate to others, make choices. It promotes positive mental health for all students. We've seen with the Be Well Indiana how much FSSA has put into that for adults. And this is the tool for students, right? To really encourage that wellness for them, not only academically and physically, but also emotionally. And then many of the mental health interventions focus on social emotional learning competencies. So those students who are getting mental health treatment are probably learning these skills with their therapist at the same time. So wanted to show that they really do overlap, but they are very different things, and one is to support the other. So this is a quick graphic that our team put together. We have a grant with Division of Mental Health and Addictions that we wrote 3 years ago, and it's called Indiana's Whole State for Whole Child, and it's based on increasing school-based mental health services. It's called Project Aware. And when we wrote that grant, we wanted to be able to tag all the other state level things that were happening to support mental health well-being. And so you'll see a variety of things on here. You know, the Governor's School Safety Report, we have a Stop Violence grant, DCS's work, CISCA's on here. So just a visual of all that's being done in the state, but really how can we come together and coordinate our efforts to make sure that we are serving the same students and families with the same language to help support them in this space. So previously to Dr. McCormick coming into office, my position didn't exist. My team did not exist. So really it's been to her passion and her desire to see this work be done, but she's directly hearing that from the field. We're hearing educators and we're hearing teachers say, we're seeing behaviors at school that we've never seen before. We are experiencing traumatic events that we've never experienced before. So how can the Department of Education help support that space? And so as I shared earlier, my background is mental health. I'm a social worker by trade. And so being able to have someone at the department who really oversees this work has been beneficial to move that forward under Dr. McCormick. So you'll see there's 3 just different tiers. We really focus on social emotional learning, mental health, chronic absenteeism, because we know kids have to be in school for so many reasons, but really focusing on how to support that. And we use what's called a multi-tiered system of support framework to make sure that we're meeting the needs of all of our students and families. And the hyperlink below where it says the work of Indiana schools, if you choose to go check that out on your own, it will show you what schools around our state are doing. So we sent out a survey just saying, what are you all doing to support the needs in the wellness, social emotional learning, mental health in your district? And we had over 200 districts fill that out to say what they were doing. And then my team has taken that data to create our work and supports for them. So on the next slide, Julie, you'll see this is just a list of our team. As we were talking about suicide prevention, a new position that was added almost a year ago was a prevention specialist. And his role is really to help schools with suicide prevention, bullying prevention, substance abuse prevention. There's a lot of trainings that schools are required to do, but we want to extend past just those required trainings. How can we really train our educators to be able to identify students who may be struggling with suicide, students who may be struggling with bullying? And so that's what our team is working to do to support. And like I said, 4 years ago, this team did not exist. And so we've done a lot of work and we're continuing to do the work based off what we're hearing from the field. So on the next slide, Julie, you'll see the resources. So since January 2019, where I shared about the social emotional learning competencies, we created a website. There are videos, there are lesson plans, strategies, supports, and ways that educators can do social emotional learning with their academic content to really help support that and to help that development. My team provides virtual and on-site professional development. In the past year, we've been to before COVID, we've been to 110 schools, sharing the same information that we have and showing them how to do this in their classrooms to really help support their growth. And then since COVID, you'll see some of the things that we've created. So we took our middle school academic standards and we took our social emotional learning competencies and we had a group of 12 teachers create how they would teach math standard 2.3 with a social emotional learning competency of critical thinking or working in teams or building your regulation skills. We put together a bibliotherapy that is books that are based off of every one of the social emotional learning skills, including race, and have the lexile level, the grade, the content, and how a teacher could use that in their space. We created a course for 6th through 12th grade students around the science of happiness. What does science tell us about what makes us happy? It's not the things that we think, money, cars, it's not that. And so really starting to build those skills for our students. So those are pre-made courses that our educators can take and do with their students tomorrow if they wanted to. We provided a list of remote social emotional learning resources. You guys have all talked several times about the virtual setting that we are in. And so that is a list of free resources that schools can use to support SEL in the virtual setting. And then last is our SEL roadmap for re-entry. So Julie, if you go to the next slide, I'll go a little bit more detail on that. As we are looking at coming back to school, whatever that looks like for schools this fall, The Department of Education created a document called In Class, but we also wanted to make sure that we focused really heavily on social emotional learning. And so that included trauma training that was talked about earlier. We've been through a pandemic. We've been through the racial injustice. How are our students going to come to us? We need to be prepared to support them. And we also need to look at our own trauma as the educators who are supporting them. So talking about the importance of that, talking about the importance of the wellness of the adults who are teaching our kids, talking about how we provide reassurance to the guardians of student safety, COVID concerns, academic concerns, how do we really support them in that space? And how do we keep that mental health services that they may have been receiving in school, how do we keep that going to support them in this virtual world if that continues? Go ahead, Julie. So a couple things I just wanted to point your attention to. Again, our team has worked really hard to make social emotional learning easy for educators to embed into their day. So we created 2 documents that are for primary age and secondary age, and it's 3 full days of how you would do social emotional learning. We feel as though as our schools were returning, they needed to have that time to connect with their students because we know we might go virtual again. And so if we don't build that rapport and that relationship right away, it's going to be really hard to pull them in when we're doing virtual setting. So we went ahead and created templates of what that looks like, the lessons you could use, how it supports all of your students. So we wanted to create that for them. And then with Division of Mental Health and Addictions, we have this Change the Frequency campaign, which is really talking about our mental well-being and how we as adults and students can own that. So we put together an activity guide that is in English and in Spanish, and it's for parents to use at home. Activities to encourage regulation, activities to encourage feeling vocabulary. So this is how I'm feeling. We know that through the pandemic, a lot of our students are expressing feelings and behaviors that they maybe didn't before. And so we wanted to put a guide in for parents to really help support them when they're home with their students, but things that can also be done in the academic day. We talk a ton about that community trust and that community building within our school. And so you'll see here, a lot of schools do what we call classroom meetings, which means in the morning and at the end of their day, they take the time to connect with the students in their space. So if that's at a high school, that's at the beginning of the period or the end of the period. So we gave them scripts on how to address COVID and the topic of race and the injustice that we've seen over the past few months. To really detailed scripts on how they could talk about that with their students, what that might look like and how they can support and build that safe environment. So wanted to provide those for you all as you work with youth as well. And last, social emotional learning and well-being for educators. This has been a strong passion of Dr. McCormick and our team, and we've created a course for educators that talks all about their own well-being. It talks about compassion fatigue. It talks about secondhand trauma and what are the things that they can do to work on themselves before they go and are in front of their students, and how can they be the best version of themselves. So there's a short clip about the video that we provide, or about the course that we have. We have over 5,000 educators that are enrolled and are working through completing that. And then we've also created just a small infographic for schools to put up in their staff lounge, their restrooms, really just encouraging adult self-care and well-being. And if they're struggling with mental health concerns, who they can contact and how they can reach out for help. So those are just some things that we've been working on to really support the mental health and the social emotional learning in the schools for our students and for our educators. So I know we are really close on time, but if anybody has a question, if we have time, let me know.
I guess my only comment is, are the teachers, when they're doing the Zoom classes and e-learning, are they told to, if they see some distress in a child, to intervene, or how is that happening? What's that look like?
Yeah, great question. So we have protocols that we have put out for our teachers. And within the protocols, also signs that a student might be struggling, right? Because we also want to think about the equity, and some students don't want to have their camera on. They don't want their home to be seen. So what are other ways that you can check in with that student to have contact and eyes on them? I know that Director Sigden would talk about the decrease in abuse and neglect reports since school was out. So we've put in signs and supports and strategies for teachers to see. And then every school has a policy on the child abuse, neglect, and report. As mandated reporters, they are to report that to their administrator or their school counselor or school social worker, and then report that to DCS.
May I ask a quick question?
Sure.
Do you, I'm a real fan of the youth survey, the youth index survey. Do you guys use that at all, or does do you get any meaningful data from it at all that you can use?
Sure. So we've not, are you speaking of YRBS?
Yes.
Okay, yeah. So we don't have weighted data since 2015, which we would love to have more data so that we could continue to build our work off of that. We would like more relative data, and also, since this has been a priority of the department, we'd like to see over the past 3 years, have we seen any change in our students and in our families? So we are always encouraging schools to participate in the survey. It tends to be a very heavy lift for schools. So we understand that as well, but we want any of the data that we can get, and we can look at YRBS nationally and be able to pull some of those trends and assume that they're for our students. But we would really love to have that for Indiana.
I'm sorry, when's the last time we had any data? 2015?
Weighted data, yeah. So that means that a percentage of the schools participated.
Wow, 2015.
Mm-hmm.
Okay, thank you.
Mm-hmm.
And Senator Bro, that's the origin of the letter of support that was in your consent packet, which we did last year for the 2019 administration of the YRBS. There will be an administration in 2021. And the way it works is the CDC picks a random sample of schools, of high schools, that would be representative of the state, and those high schools are asked to participate. The reason we don't have data from 2015 is because in 2017 and 2019, not enough of the selected schools administered the survey. And so we're really hoping in 2021 that they will participate. And that's why working with the health department last year, probably starting in 2018, the commission agreed to go ahead and provide a letter of support. So the letter that was in your packet is from the commission, and it's co-signed by Dr. Box and Dr. McCormick. So those two entities and the rest of the commission.
Julie, just for the record, I have tried to get legislation that would, and Dr. McCormick has been very helpful to me to try to get schools to, and I think even the governor took this up a couple of years ago. So we understand the importance of this. We just need to figure out a way to get it such that it is, you know, it's not just maybe it's that all schools that the CDC invites, that they actually absolutely participate, or they're required to participate if they get an invitation, or as the governor tried to do, have all schools submit some. We need to get some kind of representative data or sample of this information. So that's something for us to think about, Julie.
So the barrier that our schools see, if you don't mind me sharing, is the active consent. So if I'm a high school and I have 3,000 students and my school has chosen to do that, I have to have 3,000 permission slips from parents saying that their child can participate, because there are questions around sexual orientation and sexual content.
I'm well aware. I'm well aware.
All right, Julie, you want to take us home? Sure
will. Let's see. I'll go ahead and.
Thank you, Christy.
I mean, the slides are not very substantive at this point, but I'll go ahead and put it up. So I really just have two quick good news updates for you as the commission. We have been talking, as you know, for a while now about a review of our juvenile justice system. And I just got word yesterday afternoon that the Lilly Endowment has agreed to fund that work. So we will be receiving some funding from Lilly Endowment and contracting with the Council of State Governments Justice Center. As you all approved back in February, at your February meeting, you had a presentation of that project and created a task force to be co-chaired by Representative McNamara and Senator Kreider to do actually a preliminary phase of that work. This is actually not, at this point, a huge comprehensive review. It's a preliminary start, really to look at our data systems and what kind of data can we even get from all the different points in our juvenile justice system and from the whole state, what's at the county level, what's at the state level, They're going to do some focus groups and some interviews with juvenile justice stakeholders. We'll have a task force put together with at least several of the folks I think that are in the commission that are juvenile justice stakeholders. I'm looking at Chris and Bernice and Justin, DOC, some other folks. So that work has been funded, and we will get it going here shortly. Next step will be for me to have a conference call with Representative McNamara and CSG to just kind of lay out a timeline and a plan, and then we'll pull together that stakeholder group and start working on that. Any questions on that? And then my other update for you, as you know, I think another topic that we've been kind of trying to get our arms around as a commission is how to get more youth input and engagement on, you know, we're all here because of youth, but we don't hear from them very often or regularly. And we've been kind of trying to figure out how to do more of that. And so we've had some really great opportunities. We got some support from Casey Family Programs to do a youth and family engagement summit. We really want to do that in person. So we've actually asked for an extension on that grant so we can do an in-person event next year. That would have happened this fall, but obviously not a good time to have 200 people in a room. So we're going to try to do that next year. But in the meantime, we got some support from the Forum for Youth Investment, which is a national group that administers a national network of children's cabinets. So entities like ours that are about state level coordination around kids. And they've provided us some funding, and we're working with a nonprofit group called Voices that's a real expert in kind of youth development and youth leadership to pull together a cohort of youth, take them through a training process and prepare them to kind of tell their stories to policymakers. And so those youth are going to be, they're going to start actually next week on their training, their training meetings. There's going to be about an 8-week program, and they're going to design a virtual event that brings together youth and policymakers. So I'm hoping that all or many of you will participate and that you'll help spread the word, and it will be a chance for those of us who make decisions about youth to hear directly from youth who are impacted by our systems. So we got a little over 50 applications from youth to be a part of that cohort. 20 were selected. We originally were going to select 10. We were able to wrangle a little bit of additional funding, and we're going to have 2 cohorts of 10. So 20 youth who will go through that program, and nearly all of them have been impacted by one or more of the systems represented here on the commission. So child welfare, juvenile justice, mental health, primarily those 3. And so they're going to have some stories to tell, and they're going to be really well supported and trained in how to do that and pull together an event. So please mark your calendars. I'll have more details later, but to save the date, it's going to be on October 23rd, which is a Friday, actually the Friday after our next commission meeting, from 1 p.m. to 3 p.m. And like I said, it'll be a virtual event. We'll have a lot more details later. But if you're able to attend on that day, that would be great. October 23rd, Friday, October 23rd, from 1 p.m. to 3 p.m. Those are my updates.
All right, Julie, thank you. And I want to thank everybody that took time out of their day to be here. And it's important. So just a quick comment, if I can encourage you, what we're doing is critical. I think what we're doing is important to families, children. I'd love to see, I've been knocking on a lot of doors in the last couple of months because I get to run for an election every 2 years, and we always get competition. And it's good because it makes us all stronger. But the people that I'm talking to and knocking on doors, and there's a few, not everybody, but there's a few that really have really tough, they're in a tough spot, especially with the COVID. I've just talked to one mother that's got 4 children, all in elementary school, and 2 of them are autistic. And so with the COVID and the school learning, she's not able to go to work, so they lost half their income. And so they don't know what to do. They're kind of struggling. And so it's kind of, I don't have answers. And so anytime we can put a smile on somebody's face and make their day better, I can encourage you to do that. So again, thank you, and keep doing your good work.
Okay, I guess we're adjourned.
Thank you all.
Thank you.